Well, good evening, everyone, and thanks for joining us this evening. I'm Nancy Sanchez from the Community Relations Department here at Lucille Packard Children's Hospital, and it's my pleasure to welcome you and to introduce you to our speaker this evening. Our speaker is Dr. Alison Darcy, who is an instructor in child and adolescent psychiatry at the Stanford University School of Medicine. Her research is centered around enhancing access to evidence-based treatment, and she's led to studying special populations such as males with eating disorders, interview studies with former patients, and the development of novel delivery systems such as the use of the internet and smartphones. She knows all important. She was a senior investigator on the DSM-5 field trials at Stanford clinics and a recipient of the Academy of Eating Disorders Early Investigation Award. Her topic this evening is a unique one we haven't yet covered during the several years that we have had this lecture for the community, and we hope you will all enjoy her presentation on life after an eating disorder. Now, I want you to know that Dr. Darcy is going to be presenting, and it is being videotaped. However, we stop videotaping at the end of the presentation, and there will be a question and answer period that will be, it will not be on the tape. You will be able to access this lecture later, probably within another couple of weeks, both on the hospital's website as well as Stanford iTunes. So if you want to review some of the information, you can do that then. And again, thanks so much, Dr. Darcy, for being here.
Thanks. Good evening, everybody, and thank you so much for coming out. And thank you, Nancy, for that introduction. It is a real pleasure to be able to talk about life after an eating disorder because, you know, in this field we spend a lot of time thinking about what happens when things go wrong. So it's really an honor and a privilege to be able to think about, you know, what happens when things are going really well. And I was just speaking to Dr. Golden there, and we were saying we don't actually cover this topic enough, I think, in our field. The other reason why it's really cool to be here this evening to talk about this is that it's a very exciting time in our field. There's more people researching eating disorders now than ever before, and it's making it a very rapidly changing field. And one of the great strides I think we've been making in our field is around this topic in defining and understanding recovery. So this talk will be all about recovery. And when I was thinking about what to include in this, I kept remembering that early in my grad school days, I worked with this organization. It's an Irish support organization, much like NEDA in the US. It's called Bodywise. And I've worked with them for a number of years, and all of their literature and their website, and they have this tagline, people can and do get better. And I actually remember thinking when I first started out, I thought, that's really weird, like of course people can and do get better. But it's only after several years that you realize the prevalence of ideas that actually, you know, there might not be a full recovery for everybody, that some people will, that it's actually impossible to fully recover, to fully get over certain aspects of the illness. And so I thought that's what I would like to center this talk around, this question. And when I was looking through the literature, I found this paper, which I'll refer to later, and the first line of the paper was this: can an individual who has an eating disorder ever truly recover? So it's obviously a pretty hot topic in our field, and I would, if there was anything that you guys could leave here with today, it would be so nice if we could really demonstrate that people can and do recover. So what I'm going to cover in my talk is really how we define recovery and how that has changed over time and why it's important to our field. I'm also going to talk a little bit about what we think is important in achieving recovery, and I'm really delighted to be able to introduce you to a mother of a former patient that I had the honor and pleasure to work with, and she's going to talk to you a little bit about her road to recovery. So let me just convince you why this topic is so important, although I assume you already know because you're here. But one of the reasons why thinking about a definition of recovery is so important is from a research perspective. When we think about what treatments are effective and the outcomes for people in general, we really need to be talking about the same thing, right? So if you read the results from a study and you find that 80% of people recover after this treatment, you think, wow, that's great, that's the treatment I want to choose. And then you read another paper that says, well, 40% of people recover after this treatment. You think, well, obviously treatment A is a clear winner, right? But what if the people who recovered in treatment B, and that was a much more comprehensive recovery definition than treatment A, that treatment B might actually be the better treatment for you. So it's really important that we're all on the same page. Just an illustration of this is a table from a paper by Jim Locke here at Stanford and Jennifer Couturier, who looked at the same data set and applied different definitions of recovery that have been used in the literature, and to look at the differences in rates of achieved recovery, and it varies from 65% to 95%. So this is really an important issue. The other thing that is really important to think about when we think about recovery is how people, when we've looked at previous definitions, seem to move between disorders. So what you're looking at is the pie chart represents three sort of commonly defined eating disorders. Red is anorexia nervosa, the blue is bulimia nervosa, and the green, which accounts for 2/3 of people with eating disorders, are like everybody else who don't fit into those neat categories. The arrows and the size of the arrows are proportionate to the amount of people that move between those disorders. So you see lots of arrows going in lots of different directions, but the ones that are really important are the arrows that point outwards, which denotes recovery. So we really, if we're looking at people who have recovered from anorexia, for example, it's not really the same thing if they don't have anorexia anymore, but they have bulimia. What we really want to know is what people have completely recovered from any eating disorder. So any definition really needs to be able to characterize those people really, really well. I think probably most importantly, we need to have a great definition so that people really understand what it is that they're aiming for, right? And I will talk to you a little bit later about what that means to different people, but it's really important that both therapists and people working in the field, as well as individuals with eating disorders themselves, have a clear idea of what true recovery should be. It's really important in addition, because we know that lingering eating disorder symptoms actually and attitudes predict relapse. So we don't want to say that somebody has recovered if in 2 weeks' time they relapse. That also brings me to another factor. There should be some kind of time element into that, because on any given day we might be really, we're at top of our game, right? But then the next day, it's very easy to fall backwards. So a true recovery status should denote a reduced propensity towards relapse. So let's have a look at some definitions. So I went to this presentation once given by the senior executive in the health service in Ireland, and his name was Martin Rogan, and that's not important, but he was really gifted at visual presentation. And do you guys remember a band called The Cure in the 80s, with big hair, black eye makeup, and there was all this Cure graffiti all over, certainly all over Dublin anyway in the 80s, and Martin Rogan snapped this picture of graffiti, but it was on the wall of St. Patrick's Psychiatric Hospital. And so the irony is, it's so multifold, because we don't really talk about a cure in psychiatry. Have you noticed that? So we talk about cures from other physical illnesses, but we rarely talk about a cure. And there might be there probably is really good reason for that. I don't, for example, if somebody comes to me with a desperate fear of heights, I don't want to completely cure them of that fear of heights, because I don't want them to be doing cartwheels or skipping along the edges of very tall cliff edges, right? So certain amounts of some emotions are adaptive, they are useful. Similarly in eating disorders, and this is kind of difficult to quantify, but it's why we're looking at people returning to what is sort of a normal range, right? I also there's a certain amount of awareness of what I eat is adaptive, right? And a certain amount of awareness of how I look in the morning is adaptive. I want to know that I look reasonable enough. It's important for me to sort of get positive feedback throughout my day, which makes me feel good. But also that cure, graffiti on the side of the psychiatric hospital, reminds me of how far we've really come as a field, because our original definition of recovery was simply physiological recovery. It was absence of physiological complications. So this was really weight restoration and return of menses. So does anybody see a problem with return of menses being a diagnosis? It doesn't apply if you're male, if you're prepubertal, or you're postmenarchal. It absolutely means nothing to you, right? And of course it's important, but it's not the complete picture. In that paper that I just showed you, a table from Jim Locke and Jennifer Couturier, also they explored different definitions of recovery, as I said, but the definition that they found to be empirically, so scientifically, best fit the data in terms of variance, was a combination of both physiological recovery, so weight restored, and return of menses where applicable, as well as psychological recovery, so psychological ideas and thoughts and attitudes around food and eating and shape and weight within a normal range, so what we tend to see in the population for people with anorexia. For people with bulimia and binge eating disorder, the absence of certain disordered behaviors, which sort of maps onto the idea in the disease model, the absence of disease equaling health, right? So the absence of eating disordered behaviors was really the important piece. So that is no binge eating, no purging, and in anorexia, no fasting, or in bulimia actually. So this is the trifecta. This is our sort of most recent conceptualization of what recovery looks like. There is some really nice work done by this lady, Anna Bardone-Cohen, where she actually looked at, okay, well, do the people who achieve that level of recovery look any different to people who have, both physiological recovery plus the absence of behaviors? So, and she called that partial recovery. And do they look different to people who are actively eating disordered versus healthy controls? This was a way to basically validate, using data, this definition of recovery. So let's have a look. So this is in disordered eating attitudes. So the red bar are people who are actively ill, and the orange bar are partially recovered folks. And you can see that they are in between the actively ill and the green bar, which are fully recovered folks, and the blue, which are healthy controls. But look at there's no difference between the fully recovered and healthy controls. They're indistinguishable. When we look at disordered anorexic cognitions as well, same thing. The partially recovered folks, so people who are weight restored and have returned menses where appropriate, plus are not binging, purging, or fasting, they do not look like healthy controls. They look closer to the people who are actively ill. And again, fully recovered individuals and healthy controls were indistinguishable. Same thing with body shame. This is really quite striking to me. People who are partially recovered look the very same as people who are actively ill. The positive expectations due to thinness is this idea that if I am thin, my life will be better. If I'm thinner, things will work out a little bit better for me. And again, same picture. but actually partially recovered people looking really like actively ill eating disordered folks, and fully recovered looking much closer to the healthy controls. And the healthy controls here, by the way, had no history of an eating disorder, but they weren't super healthy controls, so like they could have other things going on, which made it a much more sort of generalizable kind of a sample. This is time spent thinking about weight, body issues, food and eating. So it's still very much on the mind of people who are partially recovered, very similar to the actively eating disordered people. But again, fully recovered individuals are thinking about food and these issues less than people who have no history of an eating disorder. And guess what? Same thing. When they asked them, how difficult is it for you when you are thinking about those things to change your mind, to think about something else? Same thing, partially recovered, sort of in between. This is urges to engage in eating disordered behavior. Same thing, I won't go into it again. And this is thin ideal internalization. So this is the extent to which individuals internalize the sort of sociocultural norms that people should look a certain way and should be thin, and that's the idealized form. They also looked at whether these groups were different on other things that weren't just eating disorder related. So they did find again that people who are fully recovered look closer to healthy controls than did people who are partially recovered in terms of the coping styles they use, with partially recovered and actively eating disordered individuals using more sort of emotion-focused coping. That is like, I'm going to be sort of led along by my emotions when something horrendous happens, rather than thinking about, okay, what can I do to make this situation better, which would be more of an action focused or problem focused coping style. And also in terms of perfectionism, which was really interesting to me, because perfectionism is thought to be one of those things that's really, really solid in somebody. And it's also one of those things that nobody really wants to give up, right? Because they think, well, you know, actually my perfectionism really helps me out. And also, same pattern when they looked at mood. Partially ill individuals, partially recovered individuals had more perceived stress, depression and anxiety that was more similar to actively ill folks than did fully recovered people. So what does all this mean? Well, people can and do get better, it's true. And that actually this idea of recovery as being comprised of those three things: physiological recovery, absence of problematic behaviors, and psychological ideas and thoughts around food and shape and weight in the normal range, is actually very meaningful in terms of the quality of life differences that we see. Obviously, we would want to follow these people over time and make sure that it does mean actually less relapse and things like that. But so exciting for our field. But okay, so that's fine. That's how we researchers, and we have this really nice idea of what recovery should be, right? And it's different. But how do people themselves define individuals with eating disorders? How do they themselves define recovery? So we did a study here at Stanford where we invited former patients, people who had recovered from an eating disorder, to come and talk to us. So this was the interview study that was mentioned in my introduction. And we had a huge range of ages. People ranged in age from 19 to 52, and but all had childhood or adolescent onset. So some people had more experience with treatment modalities than others, and we asked people to tell us about their experiences in treatment, why they dropped out, what they liked and what they didn't. And also tell us about how they defined recovery. We said, what three things would you need to have in place in order for you to know that you were recovered? We also conducted a diagnostic interview, which is a standard in the field, to sort of see where they were at themselves. And to our surprise, even though individuals themselves thought they were recovered, about half of them were not recovered by our standard definition. So that was interesting, and that later became something that we looked at in the data. But let me first show you. So this is when we looked through all of the data that people gave us, all the things that they were telling us, certain themes emerged, and this is a map of those themes. And so the first thing is that this thematic map is enormous, right? So there's a huge variation in the things that people rate as being important in their, to be in place for them to know that they're recovered. There were certain things that were symptom specific, so they're the kind of things that we just talked about in our researcher's definition, no distorted thinking, so this person said. So if there was a way of being able to really think logically and get out of this skewed perspective. So she's really speaking to, thinking not being distorted. And eating comfortably was a really big one. Being able to feel comfortable eating whatever food I want. And so we had a good mix. Physiological symptoms again, my weight would be better, my periods would come back, and then general sort of healthy functioning. Oops. Now, but look at this, right? The interesting thing was there was a huge amount of ambivalence in this sample. So about 25% of people responded, well, there's no such thing as recovery. And these are people who had responded to an ad to be, to come down and talk to us about their experience of recovery. So that was kind of depressing. This person said, I don't think there is a full recovery, actually, because I think by saying you're fully recovered, it's kind of a way of denial. We also saw a substantial amount of ambivalence in the sample. A lot of people just said, I don't know. I don't know what I would need. I'm still having trouble imagining living as a recovered person. It's it's really impossible for me to think about. I mean, can you still be recovered and still be underweight? People spoke about recovery as an ongoing process. This person said, recovery is always going to be kind of part of me, just like awareness of my body and what I'm eating. There were other parameters like social, interpersonal aspects. So people saw a resolution of interpersonal difficulties as being part of their picture for recovery. And then what I want to do to draw your attention to the last box there, other or miscellaneous factors. 40% of people gave answers that were so unique that they actually couldn't be placed in any of the previous boxes. So what that says to me really is that recovery is very individual for each person. And so when we looked at these data in conjunction with people's experiences in treatment and where they were at now, their recovery status now, a really interesting pattern emerged. So another thing that it's very different to this conceptual map. When you look at we asked the question, how did you come to being in treatment? Who's the driver behind your treatment decisions? How were those decisions made? And it was very, very clear. There was a self or within the family versus other people, right? So my parents felt that I really needed recovery. I didn't know what was going on. They got in touch with so-and-so and this happened, versus it was the doctor. The doctor gave me this recommendation. I had to go to this treatment center because of my insurance. There was a very clear difference in the way people spoke about it. It was the decision originated from outside the self, or it originated from within the family. So that's fine, right? That's always going to be the way it is. But we started to think about this thing called the self-determination theory of motivation, which basically states that, if you're involved in the treatment decisions for yourself, you're going to be more motivated to engage in treatment, right? of course, right? No shocks there. But that usually pertains to yourself being involved in treatment decisions. We had so few people having been the driver of their treatment decisions themselves that we broadened that to being family members. And when we looked at the data, we actually had we had the same result. So people whose family had been the major driver behind their treatment decisions were more motivated and were now way more likely to be recovered than people whose treatment decisions originated from outside themselves. So that was really interesting. So to conclude this, perceived autonomy in treatment decisions was significantly related to recovery status, is the short way of saying that. But also just the huge variety in how people define recovery was so interesting. Because as a clinician, I think when somebody comes into your office, you're trying to think of, well, obviously, the outcome here should be, weight gain and renourishment, and a few that they should have sort of attitudes that are just more like everybody else's. But that's really a very objective definition that has no personal meaning for that individual. So it's just so important that people are involved in that discussion of what recovery means to them, and that are involved in the discussion of like how treatment should go. For adolescents with anorexia, which were the large part of the sample that we looked at, their family involvement looked to be the same as self-involvement in those decisions. So if you're not in a position where you're capable of engaging in those discussions, the family was a pretty good proxy. So what about factors that are important to bring about recovery? So this is a kind of a summary of what's out there in the literature. And we do know that weight restoration and renourishment to a level that allows you to be sort of, cognitively, for your brain to be firing on all cylinders is really important. And we know that probably needs to happen first. We also know that people from this definition of recovery from Anna Bardone-Cohen's studies, that it really is important that people challenge those cognitive distortions that we typically tend to see in eating disorders. So things like, if I am thin, my life everything will be great. But there can still exist a small amount of that. We just need to get it back to the point where most people have that. Motivation is obviously is a really key factor. The interesting thing is motivation is a very complex idea. You can be very motivated one day and not the next. It can mean all kinds of different things. People have thought about it in different ways in terms of your readiness to recover or your stage of change, which is sort of similar to that we see in an addiction field. But we also know that support is hugely important, if not vital. So most of the studies talk about support, which can be family support, professional support. People need support to be able to recover. Effective coping that doesn't doesn't rely on emotion-based coping strategies is going to be extremely important for people to recover as well. And positive experiences in treatment, it kind of goes without saying, but it doesn't at the same time. In eating disorders, this is quite a treatment-resistant population sometimes, and if you give somebody a bad experience in treatment, they may never come back. It is really key that treatments are as collaborative as possible and that they're as respectful as possible. There is some literature to suggest that in athletes, the desire to be healthy enough so that they can return to practice the sport in which they're involved is key to their recovery as well. And I love that idea because it really illustrates that there's a change in somebody's body image so that the focus becomes on what the body can do rather than what the body looks like. And a shift in priorities, basically, that's meaningful for the individual. So I think this really speaks to people's sense of self, and that their sense of self is developed around other things, and not their eating disorders. One often hears the idea that If somebody's been ill for a certain amount of time, it becomes their identity. Right, you've heard that. But identities are constantly shifting. They're constantly in flux and they're dynamic. Like, I'm certainly not the same person I was when I was 15, thankfully. But so this idea that so people can really shift and they can move in their priorities, but it has to be meaningful for them. I'm gonna hand you over now. I think we do need to keep questions till the end, but I'm going to hand you over to Jodie Louderback, who's going to speak to you about her journey and her daughter's journey towards recovery, and then we'll just take questions at the end, if that's okay. Okay. Thanks, Jodie.
Hello, everybody. My name is Jodie Louderback, and I live in Santa Cruz County. I'm a middle school teacher. I teach middle school math, and my daughter is Annabelle. She's a senior in high school at Georgiana Bruce Kirby in Santa Cruz County. And I just want to tell you a little bit about our journey, how we came to this point, and most importantly, where we're going. And first of all, I just want to thank Dr. Darcy. I see one of the doctors that cared for us in here, and other individuals that we came across. I feel really amazingly grateful that our path led us here. It has been, it's hard for me to even remember how stressed and distraught I was when I realized my daughter had an eating disorder, and in a year's time where we are. But so thank you all so much. I could never express my gratitude enough, because I have my daughter back. I just want to talk a little bit about how I noticed my daughter had an eating disorder, and how quickly that happened. My daughter was one of those children who loved to eat. She wasn't drawn towards sweets. She liked food, the kind of food that adults usually like, that most people really want their children to eat. She's always a really good eater. She's 17 now, she was 16 years old, and I started noticing some odd behavior around eating, chopping food up and mixing things up a lot, and it caught my attention, and I thought it was odd. And as I continued to observe her, it's something that I started observing. But you don't know if your thoughts and judgments, or if you're actually observing something. But somehow it became a conscious effort for me to watch what she was eating. I do remember at her school they have a grandparents' day, and they invite family in, and my mom and my aunt came, and they go from class to class, and they have a lunch. I was working as a server. I served her, and I saw her with a big plate, and I had said something to my mom. Something's funny about her eating, and she said, no, she ate a whole, I saw her, she was eating. Well, I went and picked up her plate, and all she did was move the food around. We went to dinner that night, went out to dinner, and she would not order a dinner because she was mad at me. I can't remember. It was nothing really significant, but the flags were really going up in my mind, but I still wasn't sure. And then it was a couple days after that, I saw her get out of the shower, and I saw something that I know for sure that I had never seen before, and that was vertebra in her back. And that's when the alarm sign really went up for me. She, in the meantime, had been asking me if she could see our family counselor. And she needed to talk to me about something, and I said, sure. So I was starting to connect the dots here. So this is all within about a week span, set up an appointment with our family counselor, who she went to talk to about. She knew she had a problem, and she was trying to get the courage on how to talk to me about it. So it kind of all came, it sort of coalesced at about the same time. And so there we were with a problem. And nothing was diagnosed, but I pretty much knew what it was. I, at about her same age, also had an eating disorder. So that's why I was so quick to recognize what was going on. But I somehow got myself through it, but I have read a lot about it, and I knew that statistics were pretty bad. This can be a lifelong problem, and I was truly, I was heartbroken. I knew we needed help, so I started calling anyone and everyone that I knew that might be able to help us. Talk to the therapist, talk to the principal at the school. I have a cousin who also had an eating disorder. She's much younger than I am, and they are very knowledgeable, well-connected people. Called them. I just threw the net out. How do we treat this? How do we get through this? And most paths led to Stanford's right over the hill. You've got to get into their program. So we went to our family doctor the next day. Sure enough, she had, in the matter of about 2 months, lost about 20 pounds, which doesn't even seem possible. Like, how does that happen? But that was the true state of affairs of what had happened. So, and now we're right at about the Christmas season. So, you know, it took a couple of weeks to get the wheels turning here. She was very, a very willing participant. She knew something was not right, but still, you know, a lot of people with an emotional or mental disorder, they don't want it to be happening, but it's still not that easy to just say, oh, I don't want this to happen so it can stop, because you're sucked into it already. You can't just will it away. So it was right around the new year, so a little more than a year ago, that we began the journey driving over the hill. She did, you know, we brought her here, and she was diagnosed with having anorexia. And then it was the decision, well, what do we do? I'm a single mom. I was widowed 4 years ago. We have a farm. I was left with the care of a farm as well as a full-time job. She's in a very demanding college prep school. She is the typical overachiever, perfectionist that you know, typically is the anorexia patient. And so, do I take a leave of absence? Do I pull her out of school? I didn't really want either of those things to happen, because to me, it felt like that maybe would be a little more traumatic for both of us. And I personally know I'm a survivor, because I've had to survive quite a few, you know, unexpected circumstances in life that you wonder if you could ever do that. Well, I know that I can do that. Luckily, I was able to arrange to get we came over once a week, and I was able to arrange with my job to get that once a week off. And her school is a very wonderful, supportive, small community, very supportive environment. So we had tons of support at her school and in our community, amongst our friends and family. Everybody just came together. They were all behind us, and then she wanted to recover, I wanted her to recover, so we were all on the same page. So we began our once a week driving over from Santa Cruz, and I think that the program that, you know, I'm sure there's probably a lot of different models, or at least some different models that work to address what's going on here. Why is this? But what I think really worked for us about this program, because it has worked, we didn't get into why. We didn't get into, oh, an unexpected death, oh, older brother did things that threw us off as well. We didn't get into that, because that wasn't going to help us. What we really focused on is moving forward. I really think that if we'd gotten bogged down in why, we could have spent years analyzing and tearing things apart to figure out, why did this happen? It happened. But thinking about why wasn't going to get us out of the mud, so to speak. We had to put it in four-wheel and get out of the mud. And the focus on, I think my generation of parents have much less of an authoritarian focus on parenting than certainly my parents did. So especially after being left alone, my daughter almost kind of became my equal, my peer, rather than I'm the mom, you're the daughter. But in treating this illness, it really became important for me to have more of an authority stance as far as it's not negotiable what you're going to eat. You have to eat a certain amount of calories a day. There's going to be a breakfast, a lunch, and a dinner. There will be accountability on what you're eating. We had the insurers in the car. We had the snacks stashed around everywhere. And luckily she bought into that. It wasn't a negotiable thing. This amount of food had to be eaten. Now, I would not have come up with that on my own. So it was really helpful. We wouldn't have been able to do it without the weekly check-ins, and my daughter being a person who is inclined to math and science, seeing the graphs of the weight and seeing what it looked like on a graphic representation was a lot. Oh, we went up that much. Uh-oh, we went down a little. So it kept us really on target. Because I think had we not had that, it would have been very easy to lose track of what we were trying to do. And that's, not only are you re-nourishing the body, but you're getting that, you're changing the channel in the brain. Another thing I think I really have to add is, when life gives you lemons, you make lemonade. We really started to look forward to our weekly trips over here. We had the day off. Well, she was a junior in high school, so we would have our appointment here and let's tour Stanford. We had our appointment, let's go up to Berkeley. We had our appointments, let's go to Santa Clara. So or let's just have a fun day at a museum. So we turned it into, let's go to Sprinkles. So we really turned it into a positive thing. Now this is our 6-month check-in, and we really reminisced on our trip over the hill, how much we enjoyed our times here. And I really, when Dr. Darcy showed one of the last slides of, I can't remember, but it was points about what makes this successful, and it was the one where the athlete looks forward to running. Every single one of those points that was on that slide was true for us. And one of the things that I really have to mention is that positive connection with your treatment providers. We really enjoyed our treatment providers. We had a positive relationship. We felt like they cared. We felt like they really understood what we were going through, that it wasn't weird or it wasn't shameful. And we liked them. I mean, I don't know what process they go through in pairing you up with people, but I say we really enjoyed coming to see Dr. Darcy, and to me that was very important. I think had my daughter, I would have liked anyone that was helping us, because when you're not an adolescent anymore and you've lived life a little bit, you just appreciate people that are there that are wanting to help, whether they're warm and fuzzy or whether they're not. But I think to an adolescent, it's extremely important that they connect with someone that they can relate to and they like. And I can say that my daughter's at the stage of her life where she's thinking about careers and what she wants to do. And one of the unforeseen gifts was seeing so many young women that are in this medical profession who were an inspiration and gave her ideas about, wow, maybe I could do that. Maybe that's a career I would want to go to, because we all know when you've been through something like this, you have a unique perspective that people who haven't experienced that have. So there were many gifts in this. Would I, sign up to go through this as a parent? No, I wouldn't. Am I grateful for this experience? Yes, I am. I'm grateful for the people that we've met, that my daughter is recovered, that she is living a full life, that she will be going to college next year, that she's healthy and has a healthy relationship with food. And so I think, let's see if I missed anything that I wanted to say here. And the other thing I think that needs to be mentioned is, like any obstacle that you have in life that you really want to get over, this became our top priority. It wasn't, nothing else was more important. I mean, I was ready to say the job, you have to wait for a while. I was ready to put a lot of other things on the back burner. This, I knew, timing was very critical. The longer you wait, the harder it is. So I knew that we were really right on top of it, and that to jump in as soon as possible with as much of our focus and energy was very important. So it did become a very top priority. And another thing I have to say is, like with any, whether it's cancer or loss of job or any unexpected hardship that you have in life, it's one of those things where if you're going through this, you just have to have a lot of faith. There are a lot of good people out there that will help you. You have to open up to it. You have to accept other people's expertise and goodness. But that's one thing that we encountered was a lot of really good people that wanted to help us. And we allowed that to happen. And because of that, it was like a magical equation where it all did work out. And, I'm really happy to think that a year ago, I was desperate. And today, it's hard for me to remember even feeling that way. So that's the story of how this night came to be for us.